who are beginners, we also will cover some basic aspects and the advanced aspects or aspects of therapy that are currently being used. We will not be talking about the therapies under research or in future pipeline. So I'm just sharing my screen. Sumit has covered and told us that physiological insulin replacement in the form of either basal bolus therapy or insulin pump therapy is the correct form or is the way in which type 1 diabetes has to be managed. Unfortunately, that reality also is not yet materialized because majority of people with type 1 diabetes continue to receive inappropriate unphysiological regimens containing premixed insulins or twice-a-day insulin. So we know that sheer number of India's population makes it a country with large number of children with type 1 diabetes, which as of now has to be managed with subcutaneous insulin therapy, except for the couple of inhaled formulations which were largely not commercially successful. Most of the ways in which insulin continues to be administered are subcutaneous. Despite of a lot of advances, we continue to struggle with managing hypo as well as hyperglycemia, and the glucose control continues to be poor in many majority of the children as well as adolescents, particularly in adolescents. And there are several challenges in management. Technology has made some of these things easier. So with advances in technology, now we can see, at least in the developed world, that it is possible to achieve good hemoglobin A1C and good stable blood glucose with adequate time in range, despite of not having increased incidence of hypoglycemia, as was seen in the diabetes control and complications trial, DCCT. This is the data from India, one of the few papers which gives us a picture of what is happening with children with type 1 diabetes. As you can see that at this time, when this paper was published, the previous ISPAD guidelines had A1C targets of less than 7.5 for all the children. Now it is 7%. Now it is revised to 7%. But only 30%, less than 30% children had an A1C of less than 7.5. And a significant number of cases had severe hypoglycemia. Mind you that I'm talking about severe hypoglycemia, which includes coma as well as seizures. There are several challenges to type 1 diabetes management, and a person with type 1 diabetes fights on many fronts. In addition to their life challenges, which are not like less than any other person. So they have to take they have to remember that they have to take all insulin so many times in a day, check their sugars, calculate their carbs, take it at an appropriate time, keep a log of their food or at least a mental calculation of insulin and food, and manage lows and highs, and in addition manage intercurrent situations like sickness, exercise, exams, menses, etc. So this obviously leads to a lot of problems and burnout. And therefore, it is not surprising that many people with type 1 diabetes do not achieve the milestones or the goals that they are supposed to achieve. Now, this is the data from SWEET registry, which shows us that the target A1C of less than 7% was achieved, has been with the use of technology. So the dark black numbers, the dark black bars show the percentage of people with target HbA1c achieving less than 7%. And the light gray or the dark gray shows people using CSII, that is pump, and the light gray columns show people using CGM. Now, the use of CGM post in the past decade or so has increased significantly. So is the use of insulin pump therapy. And with this, you can see that the percentage of the people achieving the target A1C has increased. So improvement in technology parallels improvement in HbA1c. However, the developing countries continue to struggle in the form of poor uptake of technology because of several challenges, as well as infrequent blood glucose monitoring and higher or undocumented incidence of severe hypoglycemia. You can see in this diagram that the severe hypoglycemia incidence is more in Australia, and comparatively less in Asia. But a large proportion of this may be because of underreporting or inappropriate or inadequate data from the Asian countries. So what exactly is insulin pump or continuous subcutaneous insulin infusion treatment? So basically in this, we are delivering a short or rapid acting insulin with the help of a motorized pump continuously with the help of a cannula which is inserted under the skin. So the insulin is being administered continuously at a pre-programmed rate, which is the setting that we have done in this device, that takes care of the basal insulin requirements, which means that when you're using insulin pump, you're typically not using the long-acting insulin analogs like glargine or detamir or degludec. And over and above this, we take insulin boluses in proportion to the carbohydrate intake and the blood glucose value at the time of bolus dosing. The dose is calculated with the help of a bolus wizard, which means a kind of calculator where you put in the carbs, put in the blood glucose, and based on some settings, it calculates the bolus dose. Now, this calculated dose has to be manually taken by pushing a button. As of now, across the pumps that are available across the globe, the bolus insulin dose is not automated. So the pump does not automatically give insulin for your meal. You are supposed to take it manually. And if you don't take it, obviously the glucose control will not be good, which is a challenge in some of the people who are using pump therapy, that they sometimes forget to take the bolus. So this basal rate can be programmed at different times. So you can have a different basal rate in the night, different in the day. While you're exercising, you can lower down your basal rate. So it gives a lot of flexibility with respect to the basal dose adjustment. This kind of flexibility cannot be there if you take once a day insulin analog, because once you inject the degludec or glargine, the next 24 hours are not in your hand. Whereas in pump, that is not so. With the older models of the pump, there were several types of boluses that one could take depending on the composition of the meal. So for a fatty meal, one could take a square bolus because we know that the fat delays the absorption of carbs. So the rise of blood glucose following a fatty meal is quite slow. So to match that, one could take a square dose. If the meal has a combination of carbs and fat or protein, then one could take a dual bolus, which means part of it as a rapidly releasing and part of it as a slowly releasing bolus. So this is just a prototype of the common pump that is used in India. There are several companies which manufacture pump, and more or less they would look similar. There are two kinds of pump. One is with the tube pump, and there is something called as patch pump, where there is no tubing. The insulin delivery device and the reservoir are directly connected to the cannula, which is inserted under the skin. So these are called as patch pumps. As of now in India, we don't have a patch pump available, but some people do import it from the UK or US. So therefore, you should be aware about different types of pump that are available. And in this insulin reservoir, the insulin supply of 2 or 3 days is there. And with the help of the battery operated motor, this insulin is being delivered through the tubing, through a cannula under the skin. This is how the reservoir looks like. This is the inserter that is used to place the infusion set on abdomen or on the thighs of the individual using insulin pump. After being inserted, the infusion set looks something like this. It has a cap, which is a detachable cap, which can be detached briefly during shower or maybe a small duration of swimming, etc. So what are the advantages of insulin pump? Clearly, we can have more flexibility with respect to the kind of insulin that we can give. And the precision also can be better because even small insulin doses like 0.25 or less than that also can be administered. So this is particularly useful in children requiring very small amounts of insulin. Obviously, the number of injections go down because the person has to prick once in 72 hours instead of many times in a day. And now there is adequate data from cohorts and registry data to support that there is an improved glycemic control and reduction of severe hypoglycemia as well as moderate episodes of hypoglycemia. It is easier to manage unpredictable eating habits and children with very low insulin requirements. And you can use the feature of temporary basal rate for periods like exercise, stress, exam, and menstrual cycle, etc. So, in terms of quality of life and the parental satisfaction, several studies now do report a higher degree of parental satisfaction using insulin pump. There are some disadvantages. In India, cost continues to be a challenge because pump therapy is largely borne out of pocket, not covered in insurance. And challenges also with respect to the other side, that is reimbursement to healthcare professionals, because the amount of fees that is charged for any other person or insulin pump is not different. So therefore, there may be a lack of motivation with respect to the healthcare professionals to, advise insulin pump and to spend that much of energy and time educating the people for insulin pump. In the initial months, because there is no long-acting insulin, if there is an interruption of insulin delivery, within 5 to 6 hours, there could be accumulation of keto acids in the body. And this, I faced this challenge in 2 or 3 patients who have got admitted with ketoacidosis. Usually it happens with people not paying attention to the symptoms of ketoacidosis or checking their blood glucose properly, and happens in the initial few months of learning curve. Once they are primed about and adequately they are aware about prevention of ketoacidosis, this can be largely avoided. In the longer studies, actually the ketoacidosis hospitalizations are lesser in people using insulin pump. There can be issues with the patch, particularly in very thin patients, people who are very hairy or are exercising very actively and profusely sweat. The patches could get dislodged before the 72 hours. And there are additional self-management tasks. So carb counting is important for even people on basal bolus treatment, but in pump it is almost like mandate. You can't really manage a pump without carb counting. Now, who are the ideal candidates for insulin pump? I mean, largely most of the professional organizations now do agree that it can be beneficial for all individuals with type 1 diabetes, regardless of their age. Particularly in developed world, for infants, toddlers, insulin pump is a treatment of choice. Unfortunately, in India, somehow there is some resistance on the part of parents also in smaller children, and probably some resistance on the part of the healthcare professionals. But there is increasing experience even in India about insulin pump in younger age also. Conventionally, insulin pump was merely an insulin delivery device. So it was just delivering insulin as per the program in the insulin pump. Then subsequently, there was an advance in form of sensor augmented pump therapy. So the CGM, which is monitoring the interstitial glucose, communicated whenever there was a low episode of low glucose, and based on the low glucose episode, the insulin delivery was stopped. This is called as sensor augmented pump therapy. So basically, low glucose suspend feature was introduced at this stage. Hybrid closed loop therapy is one step ahead of that. So here, not only does the insulin get switched off when the glucose is low or is going to be low, predictive low glucose suspend, but also the insulin delivery can be increased if the blood glucose is high. So there can be increased delivery of basal insulin or autocorrection boluses if the blood glucose values are going high in the newer model of the insulin pump, that is hybrid closed loop pump therapy. As of now, nowhere in the world there is a fully automated insulin closed loop which gives basal as well as bolus insulin delivery, and fully automated multi-hormone closed loop. So both these are under research, and as of now, they are not available for clinical usage. There have been several studies use of HCl hybrid closed loop insulin delivery showing benefits in adults as well as adolescents, and some studies in younger children also. Previously, back in 2000, back maybe 5-6 years ago, most of the RCTs got published, and now there is also real world data which gives the benefits of HCl insulin delivery. This is one such real world study which on adolescents and young adults of hybrid closed loop insulin systems, which showed a reduction of HbA1c from 7.7% to 7%, and the improvement in time in range from 60% to 68%, from 60 to 67% in adolescents, and 68 to 73%, 74% in adults. So now we have even real world data which supports insulin pump use of insulin pump therapy. And now Let's take help of few cases to understand how we go about insulin pump therapy. So this is 11-year-old boy who's been having type 1 diabetes and using basal bolus treatment, and his A1C is ranging between 8 to 8.5, despite of Sumit did point out that people with type 1 need to check their glucose 7 to 8, 10 times a day. Unfortunately, with multiple prickings, in real world, people hardly manage to check it 4, 5 times a day. That too with a lot of motivation and persistent efforts. Many people don't even do that much. So there is a certain capacity or capability of these older ways of managing type 1 diabetes. So this guy was maintaining a A1C of 8 to 8.5, and this was his CGM, which unfortunately was not very great. And several challenges, particularly in the daytime, in the school time, were there. So there are frequent lows in the morning, preventing adequate breakfast dosing. So because the sugars were low in the morning, he was not taking a breakfast dose, and therefore having high sugars in the school, again having a lunch in the school without insulin because he was shy. He was wanted to have a discreet, he didn't want to disclose about diabetes, so he was not taking insulin in the school. And now he's come wanting an improvement in his blood glucose control. Now, can insulin pump help him? Now, he was waking up with a morning low. So insulin pump is shown to have reduction of nocturnal hypoglycemia because you can give a different basal rate in the night time. And it can enable the child to have a discrete dosing in the school without having to, take out a pen and, administer the dose. Avoiding also because in the morning he's not really hungry for a heavy breakfast. So therefore, it is against his appetite to kind of force him to have breakfast and a morning insulin, and then not take anything in the school or take a very light meal in the school, whereas all his friends are enjoying the lunch. Is he the right candidate? The first thing that we always see is affordability, wanting to use technology or motivation, reasonable basic diabetes management skills like managing lows, sick days, carb counting, etc., and a cohesive family, and demonstrated compliance to follow up. So he was switched on to insulin pump, the conventional, the previous models of the insulin pump, not the hybrid closed loop pump. And there was a significant improvement with respect to, as you can see in these two CGM. Also, the second CGM is also not ideal, but there has been much more improvement as compared to the previous CGM, and the estimated A1C has come down from 8.8 to 7.7%. Lab A1C declined from 8.8 to 7.4% with reduction of hypoglycemia. So improved control and less hypoglycemia, and improvement in cooperation from the child and confidence in the family. So, for example, in this case, this insulin pump treatment was very, very helpful. Now, second case is a 19-year-old boy with A1C of 12%, type 1 diabetes. And his history showed that he's just not bolusing. He's only taking basal dose and forgetting to bolus or not taking bolus at all. We discussed all insulin regimen options and encouraged him to send BG logs on phone. He returned in January 2018, again with the similar kind of picture with A1C of 15% now. Now, we did advise him to change to basal. So he was using insulin pump, and his pump history showed that he has not taken bolus. So these kind of people are not ideal candidates for insulin pump. So therefore, here we advised him to change to basal bolus treatment, which probably at least you are forced to take those boluses with the basal bolus treatment. I'll just probably wind up with the last case. We'll not discuss the pump settings. That's a separate, matter of discussion. There are several settings that total daily dose is the basic setting base, which decides the subsequent setting. Sumit did cover some of these settings in her talk. Insulin carb ratio, sensitivity factor. There's no difference from basal bolus and the insulin pump. They are calculated with the same formula. And we keep a pre-meal target of 100 to 120 in most of these individuals when we are using insulin pump. We've covered the bolus insulin calculation. And we've covered the risk of ketoacidosis. So I'll just switch to last case. So this is a child who is using insulin pump 640G with Libre sensor and the A1C of 7.2 to 7.8, and she wants to go on the new insulin pump. These are her settings and insulin carb ratio correction factors, active insulin time, etc. And this is her pre-treatment CGM. This is a black and white copy. And daily curves showing some of the challenges of insulin pump, like hypoglycemia followed by hyperglycemia. Again, multiple snacking without probably missed bolus or inadequate bolus. So this child was put on the new pump, that is the hybrid closed loop or 780G pump. And this is the 6-month follow-up of this particular child. You can see that the A1C A1C has not shown much improvement, but the time in range has significantly improved. So this also tells us that HbA1c does not really give us a complete picture. So this time in range may have improved owing to reduction of hypo and hyperglycemia, whereas HbA1c does not, really reflect. HbA1c can be falsely good if you have wide swings in your blood sugars. And this is the follow-up CGM. You have seen the baseline CGM, and the follow-up CGM shows a very good control in the nighttime. Some fluctuations are there still in the daytime, but it does not guarantee that just by putting on 780G you will get 100% good readings. You still have to do several things correctly to get good results, even on the advanced therapies. So I will just end my talk by saying that insulin pump is amongst the currently available therapies, it's the most physiological way of giving insulin. It's not a panacea, it's not a magic wand for diabetes care, but it is a way to improve diabetes control and have a good, flexible, and a life of good quality. It is associated with improved glycemic control and reduction of low sugars, but it is very important to select appropriate candidates for insulin pump and pay attention to diabetes management, other aspects like injection site rotation, diet, physical activity, etc. Thank you.